Well, good afternoon, everyone. This is Shane Hamster from ARTA International. I will be your technical host for today's webinar. If you have any technical difficulties, you can get my attention by using the icon at the top of your screen of a person with their hand raised. You click that, and I will be sure to contact you. Also, on the left-hand side of your screen, there is a Q&A pod. Right now, if you could, enter your name and email in that Q&A pod so we can make sure that you get the materials from the webinar today. And we also get an accurate account of who's attending. Again, the Q&A pod is also a good way for you to send a question to our technical assistant staff. We're a minute after 3 o'clock, so I am happy to hand over to our presenters today to get this webinar beginning.
Good afternoon, everyone. This is Sari Schumann with the National Alzheimer's and Dementia Resource Center. Welcome to our webinar today on measuring program impact, designing and implementing a program evaluation. The purpose of this webinar is to provide you with helpful, current, and applicable information for your AD-SSP and ADI grant projects. Today's webinar is being recorded and the PowerPoint presentation will be sent after the webinar. We will allow time for questions through the webinar's chat feature at the conclusion of the presentation. If you have a question during or after the presentation, please enter your questions in the chat feature. Also, if you haven't already done so, in order to find out who is on the webinar today and to ensure we get the slides to you after the event, please type your name and email address into the chat feature at this time. Today we will hear from Michael Lepore about measuring program impact. Michael is a senior health policy and health services researcher with RTI International and an adjunct assistant professor in health services, policy, and practice at Brown University. Prior to completing his Ph.D., Michael worked for 2 years in the dementia care unit of an assisted living facility. This experience motivated his contributions to long-term care research. His research career has focused on issues concerning residential long-term care, including personal care homes, assisted living facilities, and nursing homes, and has centrally attended to questions of quality and equity. In addition to his contributions to research, Dr. Lepore has collaborated on quality improvement and culture change efforts with long-term care organizations in the United States, Canada, and the Netherlands. Currently, Michael is involved in several long-term care research projects, including the development of new measures on nursing home quality for use in CMS's 5-star rating program. We welcome Michael and thank him for his presentation today. Michael, I'll turn it over to you.
Thank you, Sari, and good afternoon, everyone. I also would like to thank Sarah Karen for her substantial contributions in preparing the materials we will cover today. We're going to cover 6 main topics today. First, we'll discuss the purpose of conducting an evaluation. Then we will cover how to organize the evaluation with some specific attention to using a logic model. Then we will discuss selecting measures for use in the evaluation, collecting the data, analyzing the data, and then ultimately using the data that have been collected. But first, let's ground ourselves in a common understanding that evaluation is a systematic way of learning what works, why something works, how it works, how well it works, and ultimately how to make things work better. And the results of an evaluation can be used to decide if you should continue doing what you're doing and how you're doing it, or if you should change how you're doing it or what you are doing, and ultimately to encourage participation and support from others, including program participants, but also funders. So a critical first step in planning an evaluation is to clearly identify the goals of the program or the services that are being evaluated. It also is important to make sure that the goals of the program or the services are shared by key stakeholders, including participants and funders. And we will want to avoid attempting to evaluate a program without very clearly understanding its goals. For example, if we were to implement a program that reduces caregiver stress, but it doesn't have an impact on Medicaid expenditures, and we were to determine these outcomes through evaluation, would we consider this program a success? Well, we would need to evaluate what the goals of the programs are to determine if it is a success. If the goal is to reduce caregiver stress and reduce Medicaid expenditures, then the program has not achieved its goals and thus would not be a full success. However, if the goal is to reduce caregiver stress without increasing Medicaid expenditures, then the program would be deemed successful. With the goals of the program in mind, a logic model can be a useful tool for planning your evaluation. The logic model shows the basic structure of your program. It starts with inputs, which are the resources you need for your program or your services, such as time and money and equipment and staff. The inputs are used to create outputs, like the types of activities that you are doing, such as workshops or trainings or coordination across providers, as well as participation in those activities by individuals, by groups, or by agencies. And then as a result of participation in these activities, you seek to achieve certain outcomes. And these outcomes may be immediate, occurring right away, or they may be short or medium or long term. And they can be positive outcomes, negative outcomes, or they also can be neutral, such as not affecting something. So as an example, increasing care workers' knowledge would be a positive outcome. And this outcome may be measured immediately, such as right after a training session. And it also can be assessed in the short, medium, or long term, such as through 30-day, 90-day, or 6-month follow-up assessments. And evaluation plans can build on the logic model so that it is clear which outcomes need to be assessed and the pathways by which you expect these outcomes to occur. And when there is clarity about the targeted outcomes of the program and the inputs and outputs that will help achieve these outcomes, then we can turn to designing the program evaluation. And a pre-post design is a commonly used method. With this sort of evaluation, we can compare program participants with themselves before and after the program. This sort of evaluation has several advantages, such as only having to gather data from one group, that is your program participants. The information collected can be part of your ongoing program management, and the interim results can indicate areas where modifications to the program may be needed, so you can make adjustments in real time. However, there are also certain challenges with this sort of pre-post design. People who participate in the program, they may not be representative of others. The outcomes may be the result of other external factors that happen by chance at the same time as the program, and thus the outcomes may not be due to the program per se. For instance, people may become more depressed over time if an economic recession is happening. And then some things might just change naturally over time regardless of any program or service, such as folks with dementia may become more impaired over time. And there also are other design, evaluation design options other than the pre-post design, such as a pre-post design with a control group or a randomized controlled trial. However, with both of these designs, there also are drawbacks. First, and perhaps most importantly, with both of these sorts of design, not everyone takes part in the program who's included in the evaluation. Only those who are assigned to the treatment group take part in the service or the program. The control group would not participate. And there's also then an added cost of collecting data on these two groups of people both the treatment group and the control group who are not actually receiving services. So part of planning the evaluation is selecting the measures that will be used to determine if the program goals are achieved. And for each goal, a different measure may be needed. For example, if aiming to reduce depression, you may select to use the PHQ-9, which is a 9-item depression scale of the patient health questionnaire. Or if aiming to increase providers' knowledge about dementia, you may select to use the Alzheimer's disease knowledge scale. If aiming to improve coordination between physicians and community organizations, you might seek to measure the number of referrals from primary care physicians to partner organizations. And if you're aiming to better address the needs of persons with dementia living alone, you might use a measure of the percentage of partner organizations that use a standard protocol to assess the needs of these individuals. But ultimately, having specific measures for your specific goals is needed. And as the measures that will be used are determined, you will be able to plan for collecting data. And developing a data collection plan is essential to make sure all of the required data are collected. Some tools that you would use, like surveys and questionnaires, are completed by the participant, and these collect information in a structured, systematic way, in a standardized way. And some benefits of these instruments are that the information can be submitted anonymously, and the data can be relatively easily analyzed. Interviews and focus groups, in contrast, require face-to-face interactions with participants or perhaps phone calls with participants conducted by trained personnel. And however, these modes of data collection are particularly valuable if you want to get in-depth information, particularly if you want that information in the words of the participants. Clinical abstraction, another way of collecting data, requires access to the clinical records, as well as a trained person who uses a structured protocol to abstract the data. This may require a significant investment of time, and it may present challenges to obtaining permission to access and use those data in a way that still maintains confidentiality of personal information. And administrative data from participating providers also may be useful in your evaluation, but there also may be issues of confidentiality, and different providers might collect data in different ways, and that can make it hard to assure the comparability of information from the different data sources. Now, ultimately, the relative ease or burden of data collection is important to consider when making your data collection plan. I did want to highlight that early in the new year, the Resource Center will be distributing a resource list of potential measures that you may consider using in your projects. Examples of some of the types of measures that will be included in the resource list are dementia screening instruments, measures of depression and burden and self-efficacy for use with caregivers, quality of life measures for persons with dementia, as well as measures of behavioral symptoms and mental health, and measures for use with providers, such as those assessing knowledge and attitudes and their person-centeredness. And the guide will include information on where to find the measure, including direct links when those are available, and also how many items there are in the various data collection instruments, and some sample questions and other sorts of key information. And if you are in immediate need of suggestions for measures, you can contact your Resource Center liaison at any time. Turning now to actually collecting the data. This is time-consuming, both for the data collector and often for the person supplying the data. And collecting data also can be costly. And so for these reasons, it's important to only collect the data that is required to be collected under the terms of your cooperative agreement, and the data that you are actually going to use and which is linked to your logic model, and not to collect data simply because you think it would be interesting. Interesting data rarely actually gets used. So with this in mind, planning for data collection is a critical step. And one key issue to consider when planning data collection is who will collect the data. Will it be someone from your organization, or will it be a separate service provider or sets of service providers, or maybe an independent external evaluator, or some combination of these? And when determining who it is who will collect the data, you will want to make sure they are capable, trained, and well prepared to perform the data collection. If there are multiple people collecting data, it is particularly important that they all are collecting the same information with the same common understanding and working with the same key definitions and the same understanding of the intent of different items, and that they are not relying on their own interpretations of data collection tools, and making sure that all of the data collectors, if there are multiple, are well prepared, and even if there's only one, that he or she is well prepared, also helps to avoid having any errors in the data that are collected. It's also important to make sure that people collecting the data have relationships with the individuals from whom they're collecting the data that will support them to collect data that are accurate and to do so in a timely manner. We'll want to avoid introducing any bias in selecting these individuals, such as having someone conduct an interview to evaluate a training if they were the same person who gave that training is something we'd want to avoid, because the participants might feel obligated to say how great the training was. It's also important to remember that the OMB data on persons with dementia and caregivers, those must be collected on everyone, on all of the participants. And you will want to plan how many people will be included in the data set. If there are too few people, or if the participants are not representative of the people you serve, you'd be limited in what you can say about the success of your program. And planning for data collection commonly also requires having various materials and other materials prepared. This may be survey forms or questionnaires, and possibly also envelopes and postage, or it may be laptops or tablet computers. You may also need a meeting space and refreshments, such as if you're doing focus groups with many individuals all at once, or a private meeting space or a phone line may be needed for one-on-one interviews. Also, you may need to plan for car or ground transportation if doing interviews or observations in a person's home. And if attempting to collect information by mail, which is a relatively common approach, it's important to remember that many people may not return their surveys. You may need to send follow-up surveys when that first or second survey is not returned, and it's valuable to decide in advance if you'd also want to make phone calls to people who don't respond to the mailed surveys. But also, all of these different factors will affect the timing of the evaluation and the costs of the evaluation. So while planning your data collection, it's also important to account for when and how often the data will be collected. So with a pre-post evaluation design, which is very commonly used, data would be collected before the start of the program or introduction of services, and then again after the end of the program to assess its impact. And follow-up assessments, such as 30 days, 90 days, 6 months, or a year later, also is particularly valuable to help determine if the program has a lasting impact. And even with a strong data collection plan where when the data will be collected and how the data will be collected and who will collect the data are all thought out in advance, it's still important to remember that people have limited time and willingness to participate in the evaluation. You may get less participation in each subsequent wave of data collection, so perhaps there would be a great response rate in an immediate follow-up, but a little less at 30 days and even less at 90 days, and dwindling more at 6 months or a year as folks drop out over time. And those who do participate in multiple waves of data collection, they might be different from those who drop out. They may be strongly committed to the program or they might be very frustrated by it and want a chance to share this frustration. But in either case, they might differ from the people who don't respond or who drop out over time. So the information that's collected may offer a skewed perspective. Um, and when you do have low response rates, you'll be less able to draw conclusions from your data. So encouraging people to respond is important, but it also takes a substantial amount of work. One way to encourage high response rates is to make sure that the evaluation itself is directly relevant to the participant. That is, to make sure the evaluation or the specific assessment questions address the very reasons why people might have for taking part in the program or being engaged in the services. And collecting data, it's not necessarily easy and it can be costly, but thinking carefully about how you want to analyze your data, what you'll do with it down the road, can help. And thinking through what you want to show with those data, how you want to show it, those things can help save time and money by planning in advance. And planning early means that time won't be wasted collecting data that wouldn't be used later. For example, a goal of an evaluation may be to compare how a program works for people with different English language skills. Once you start planning, though, you could realize that you don't serve enough people with low English language skills to do a separate analysis and compare this group to another. So in this sort of situation, the data collection plans might need to be changed, so only the data that can be used are collected. And thinking about the types of analysis that will be conducted and the skills required to conduct those analyses also will help in making sure that the right team is in place to do the work. It's oftentimes the case that the labor costs, the team costs, are the biggest part of a project, so having that team in place in advance will help with budgeting and scheduling. And developing this analysis plan early on is important. Without an analysis plan, you may collect the wrong data. You may not have the right resources available to analyze the data. And it may cost you more time and money and possibly frustration to get those data that you do need. As you collect data and prepare for analysis, you will want to make sure the data are cleaned of any errors. And errors can occur in a few ways. For instance, errors can occur in coding and in data entry, such as when entering data from handwritten survey responses into a database or typing up handwritten notes, and having the data double-checked by a second person is one very useful and simple approach to catch errors early and catch them before they're repeated over time. And doing the data cleaning during data collection, that is identifying any inaccurate records and removing them from the database while still in the process of collecting data, that could help to correct any errors that are identified without having to collect additional data. And it could help prevent future errors from happening. It's also valuable. You may need to organize the data to prepare them for analysis, and doing this early on is helpful. For example, for quantitative data, you may input the data into a software program that will be used to analyze them as you're still collecting them. And Excel may be the tool you decide to use. For qualitative data, such as recordings or notes from focus groups or interviews, you may need to type these notes into a word processing document so that they can be easily read. All of these are necessary steps in the process of analysis. And the data cleaning and organization can be time-consuming, but there's no value in analyzing incorrect data. So do be sure to allow adequate time for cleaning the data when planning your evaluation. Now, once the data are cleaned, then we can shift over to analysis. And data analysis will generally start with calculating some descriptive statistics when working with quantitative data. And this may be the numbers and percentages of participants of certain characteristics who are a certain age or race or gender, and any measurement scores, say from before and after the program or services are delivered. In calculating these percentages and mean scores and other descriptive statistics helps give you a good sense for your core findings. You then can test the differences you are seeing in the descriptive statistics by calculating inferential statistics, which help you determine if the differences you are seeing are meaningful or if they're just due to chance. For example, in a pre-post evaluation of a service that aims to improve quality of life among persons with dementia, you may see improvements in quality of life in your descriptive statistics, such as with a mean score among all participants on quality of life being higher after a service versus before a service. But you want to be sure, as best as you can be, that those improvements can be attributed to the service and that they are not simply due to random chance. And with relatively simple statistics, you can determine this pretty well. For example, some relatively simple inferential statistics can help you determine if the results that you obtained represent meaningful change, how likely it is that the impact you see would be found if you expanded your program or service to a larger population, and how well your program or service works for different types of people or in different situations. So there are a couple common statistical tests that may be particularly useful for your evaluations. The choice of statistics will be driven by the type of measures that are being used, but regardless of the statistical test that is being used, the statistical significance is generally shown as a p-value, which indicates the probability that your results are a matter of chance. And the smaller the p-value, the less likely it is that your results are due to chance. So oftentimes, the smaller the p-value, the better. A t-test can be used to compare the average numeric score across two groups, such as a measure of caregiver emotional strain that results in specific numeric values. The comparison of these scores could be made between the same group of people, such as pre-test and post-test groups. So that would be the same group of people before and after a service or program. Or this sort of test can be used as a comparison of two different groups, such as men versus women or older versus younger people, to see if a program had different effects for different groups of people. In contrast, the chi-square is a commonly used test to determine if there are differences between two or more groups with regard to categorical data. And categorical data might be non-numeric, such as people who say they were helped a lot versus those who say they were helped a little or not at all, different categories. But it also might be groups or categories of numbers, such as people who had low emotional strain in a certain range of scores, or medium or high emotional strain, with each of those categories representing a range of scores on, say, a caregiver emotional health strain scale. But in either case, with numerical scores or categorical data, these sorts of inferential statistics will tell you if the differences between the groups being compared seem to be due to chance, or if there's some real difference that would be maintained if we continued implementing and evaluated the program with more participants. Now, calculating these types of statistics, like the chi-square and t-tests, has become increasingly easy to do in Excel. Other software programs like SPSS also can be used. However, Excel tends to be very widely available, and it can work rather well for data cleaning, such as identifying values in the data that are outside the possible range of values For instance, if you see an age pop up that's over 150, you would know that you have an error. Also can be used for calculating descriptive statistics, such as the averages and percentages or ranges of scores in your data. Excel also can be used to create charts or graphs or figures to display your data visually. Which is very useful when communicating to various stakeholder groups to display the data in different ways rather than just in tables. And finally, the software can be used for conducting the statistical tests we were just discussing, like the chi-square tests and the t-tests. And there are now numerous resources available that provide guidance on how to conduct these sorts of statistical tests in Excel, including recently published books, but also a variety of websites, some of which include video tutorials, which may be very helpful. And a few of these resources are included here in the slide deck for your reference. So after analyzing your data, and then what? Where do you turn to then? Well, the information from the analysis can be used to answer the questions you were concerned about. For example, are the targeted outcomes indeed being achieved or not? Are the outcomes being achieved differently among different groups? Different groups of individuals, different groups of service providers, and different areas or locations? Do the results suggest that changes are needed in certain aspects of the services? And these sort of questions are often informed when, again, referring back to the logic model and knowing what outcomes are expected from certain inputs and outputs. And then, does the logic model perhaps need to be revised? Answering these questions will help inform how to move forward with refining the program. And you also will want to document your findings, specifying what you did, why you did it, how you did it, and what you learned, and engaging in this process of documentation and during the course of program implementation and evaluation is helpful so that it's not all reliant on looking back over time, but capturing that information in real time while it's happening. And using your findings to learn where there are problems and what you can do better, to learn what is working well and how you can build upon that and expand upon that. And by capturing all of this, documenting all this information, it can be shared with your participants and collaborating partners, and also can be used to provide evidence of the value of your work for your sponsors, or funders, and potentially for future funders as well. And generally, the evaluation findings will help us determine what to continue to do in a program or service and what may need to be changed or modified. So we've covered a lot in just a short amount of time, so I'm going to provide just a brief summary to try to capture some key points as we lead towards opening this up for discussion. So in recap, I want to emphasize that evaluation is a critical component of your work. It helps you learn if your program is working as desired and how it can be improved. It provides evidence of value to your stakeholders, and it guides future actions. And it can help gain funding and help defend against program cuts when they occur. And a good evaluation requires careful thought and planning. Using a logic model can help you carefully plan and describe your program, including what you hope to achieve and defining that clearly and early on, and how you will achieve it. This requires being clear about what you want to learn from your evaluation as well. It's also necessary to choose measures that clearly reflect your desired goals. And again, the Resource Center is happy to offer support in the selection of measures. And planning carefully for data collection really is necessary to collect the right information and the right amount of information, but also to do so in a timely and efficient way. And it's important to analyze and present the data in ways that will be useful to your intended audience. And the way the data are presented may need to vary depending on who the audience is. And finally, the Resource Center has several items that can help you with your evaluation efforts. So in addition to having access to this presentation, we have a previous presentation by Josh Weiner for the ADSSP grants. We also have access to the Nevada ADSSP grant statewide evaluation of dementia capability. That's from the Sanford Center for Aging at the University of Nevada, as well as the Maine ADI grant evaluation plan. And both of these can provide helpful models when planning your own evaluations. And as noted earlier, the Resource Center will soon have more materials available to select your selection of measures. So I'd like to thank you for your time and attention this afternoon and open it up for discussion and questions, and note that we do have a wider panel available for discussion and questions. So thank you again.
Thank you so much, Michael, for your presentation. It was really helpful to hear everything that you had to say. We do have some questions that are already coming in, but I do want to remind those of you who haven't sent your name and email address. If you do so, that would be great. That way we can send you these PowerPoint slides at the conclusion of the webinar. In the meantime, while people are sending those in, let's get to some of the questions. The first question that came in is asking, well, actually, step back one second. Michael did mention there are a few other people that can answer your questions here. You might hear two others possibly join in to answer questions. One is Sarah Karen, who you heard assisted with these slides today, is also at RTI International, and Josh Weiner, who is the co-director of the Resource Center and also hails from RTI International. So let's get to these questions. There's a few coming in here. The first question was asking if one of you could talk a little bit more about the difference between formative and summative evaluation.
So this is Josh Weiner. So formative evaluations is typically gets more at the process of implementation, analyzing the issues related to getting the program up and running, and answering the questions of whether or not the program that was implemented was actually the program that was originally designed. There's a lot that happens in putting a program together and operationalizing it that can get in the way of actually having it as it was originally designed. Summative evaluation typically gets more at the outcomes of a evaluation, as Michael alluded to. Were Medicaid expenditures reduced? Was caregiver burden reduced? Did the person stay in the community longer before going into a nursing home? Things of that nature. And as it is sort of implied by the name, it typically tries to look at the overall impact of the program or the intervention.
Thanks, Josh. The next question might be yours also. There's a question of asking if there's a goal to standardize measures used across the various funded ADSSP and ADI projects.
Well, we certainly would like, to the extent that it makes sense, to have measures be the same so that we can look across programs and see which programs have been more effective than others, and as part of what the Resource Center is doing. As Michael indicated, we'll be sending out some guides to various commonly used measures in the literature, and we have been reviewing the evaluation plans for grantees to try to identify measures that go across a number of grants. That process is still somewhat underway, or still underway. But I think that that would really be great if we could come to an agreement across the grantees for using the same measures. That may not work in all circumstances, but it certainly allows looking across programs, and to some extent may allow merging of data and trying to look at things more across programs.
Great, thank you. There's another question that came in specifically about evaluations for these ADI and ADSSP projects. The grantee is mentioning that a conversation about their project and their work plan indicated that there was a preference for a pre-post design as opposed to a design using a control group, since it would delay provision of services to some people. And is that still an accurate understanding of what should be done for the ADI and ADSSP projects?
So unfortunately, Erin Long, I don't think is on the call today. She couldn't make it, but in my meetings that I've attended with Erin, she has made it clear to grantees that these are primarily operational grants, cooperative agreements. They're not primarily research programs, although they do have a requirement that there be an evaluation to some extent. So Erin has expressed a preference for a pre-post design. That is a simpler design and one that does not require collecting information from people who are not in the program. But as Michael made clear, if you're trying to actually figure out what the cause of the outcomes are, there are limitations with a strictly pre-post design. It could be that things just kind of naturally happen over time, such as people getting worse with dementia, or it may be the effect of outside events such as the overall economy. But a pre-post design is a respectable way to try to do an evaluation of these kinds of programs, and is, I think, ACL's preferred method.
Great, thank you. Another question is asking what type of data or measures could be used to evaluate the pre-post dementia capability of programs. Any ideas from the three of you?
Well, Sarah, do you want to talk about
Sure. Did you have anything you want to add besides the dementia capability assessment?
No, but I'll chime in after you finish.
Okay, great. So the grantees received a dementia capability assessment tool a few months ago, and most have submitted those. Those tools provide an opportunity to evaluate the dementia capability not only of the grantee organization, but also of the partner organizations that they are working with in 3 different domains. The idea behind the tool is to use it periodically to assess if the dementia capability of the various organizations is changing, and where you might want to go with different programming to enhance dementia capability in a certain area. So if you are part of a team where you haven't seen that tool yet, you can talk to the grantee that you are working with. Additionally, I will post my email address at the end of the session. You can send an email to me, and I'm happy to get that tool to you so you can take a look at it as well.
So I wanted to just add two things. One, so there is not a lot of measures out there in terms of dementia capability, and I think we're kind of at the cutting edge on that kind of issue at the systems level. And then the second thing is that I think so there are some specific questions in the assessment form that we've developed, but I think it also identifies a number of domains about which or from which grantees can think about their own questions and how they fit what they're doing, and build on that in terms of looking at the activities that they're actually involved in, and take the evaluation from that point.
Great, thank you for adding that. Another question came in: what type of aggregated data, health, demographic, social, or economic, could be of interest in evaluating the provision of a dementia program? And I know that will vary based on what the program is, but are there any ideas that any of you have that you would want to share here? We do have, as part of the requirements of these grants, you do have to collect some demographic data that is collected on an OMB approved spreadsheet that all the grantees should have available to them already. Again, that's something that your Resource Center staff person, whoever is assigned to the grant, can get for you. But otherwise, for health, social, economic data, are there any tools that any of you can suggest or think of?
Well, I don't have specific tools, but I think the research literature is clear that utilization of services and prevalence of dementia varies greatly by socio-demographic characteristics, and so it's important to try to take those into account if you have enough sample size to do that. As Michael indicated, if you don't serve very many African Americans, then it doesn't make sense to try to analyze them separately. But if you do, then it would be useful in terms of operating the program to do it that way, or to do it by other racial and ethnic groups, or by location. Some locations have better access to things like transportation and services than others. But you have to have adequate sample size. The other thing I just wanted to mention is that we will have a webinar next month that maybe Sarah can provide more information on, relating to socio demographic and racial disparities and Alzheimer's disease that will take place next month.
Great, thank you. Yes, on January 7th, we have a webinar, as Josh mentioned, on racial and ethnic disparities in dementia. And if you, again, you can contact me if you didn't get that information for the webinar, but all of you probably should have received it either from me or seen it through the ACL e-news that comes out. So I will send out my email or post my email address at the end of the webinar here. So let's see. Another one question was, is there I know that there were some references put up in your slides, Michael, but is there a good basic reference book or that folks can use for evaluation tools, something that kind of has the basics laid out?
Nothing's coming to mind right off, I think the references given already are a good place to start. And otherwise, certainly, ask your resource center, ask other resources in your community for assistance.
Right, and on the slides that we'll send, you'll have those resources available to you shortly. If there's other questions, please enter them into the chat feature. We'll give a few minutes for folks to do that.
And this is Sarah Karen speaking. As people are entering other questions, I want to just add to Josh's response to the previous question in terms of doing analyses by different subgroups, whether those be economic or racial or ethnic or gender or whatever it may be. Just to reemphasize a point in Michael's presentation that there are these two levels of analysis. So if you start with the descriptive analysis, you can look and see, how many people did you serve in these different groups, and that's going to give you the information you need as you move forward into the inferential analysis of whether you really have enough people in these different groups to make it worthwhile to do some comparison, or if you have enough people for you even to be able to do a comparison among these groups. And I think doing that kind of descriptive analysis gives you that information. It also lets other people know as you present it that, oh, it's not that these people didn't think about doing it, but rather they thought about, they considered it, and there's a reason why these comparisons were not done. So it presents you as in a stronger light of really knowing who you're serving and what the key differences are.
Great, thank you. I don't see any other questions coming in at this time.
So,
yes,
Sarah, if there aren't questions, I just wanted to reiterate one point that Michael made, which is collecting data is really hard because most people, especially in dementia programs, have a lot of other things that they have to be doing or rather be doing. And so it's a burden on them to respond. So in order to get the data that you need to be persistent and to plan on going back to people repeatedly in order to get enough responses to do meaningful analyses. Now that can be reduced if you integrate the data collection into the provision of the services, but then you get to some of the problems that Michael alluded to, which is that to the extent that you want the people to be commenting on the service provider, you don't necessarily want the service provider to be collecting the information. But to the extent that you're collecting information about, say, caregiver burden, then you may be able to have the service provider answer questions on that. But if you're running a program that serves 300 people and you've only got 15 responses, then you don't have a whole lot that you can say. The other thing I just wanted to emphasize is that the Resource Center has substantial expertise in doing research and evaluations. And our reason for being is to help grantees accomplish their goals. And one of their goals is to conduct a meaningful evaluation of their initiatives. And so if there are things that we can help, both generally and specific to your grant, please don't hesitate to contact your liaison, and we'll work with you.
Great, thank you. You know, there's just one more question that came in from someone who may be a newer grantee that I just wanted to address real quickly. Is they're asking about the relationship between the Resource Center and the folks at RTI and the funder and the grantees. So just real briefly, the RTI has the staff that make up the Resource Center. The Resource Center receives funds from the Administration for Community Living to run the Resource Center and provide technical assistance to all of the grantees. So you separately as grantees receive funding from the Administration for Community Living for your grant. So we partner with ACL to provide that technical assistance to all of you through these webinars, through reports that we send to you, and through a number of other vehicles. So I hope that helps answer that question for everyone. Do any of the folks that have been answering questions have anything else they want to add before we close out? Well, hearing none, I would like to thank Michael Lepore for his presentation today, and also Sarah Karen and Josh Weiner for helping out with the question and answer session. And most importantly, thank you to all of you who have joined in with the webinar today. I will get the slides out to you as soon as possible within the next day or so. And I wish everyone has a nice afternoon and a nice holiday week. Take care, everyone.